Hello everyone and welcome to Cardiovisual. I'm your host, Matt. Today we're going to do another cardiac patient scenario that I had as a paramedic. So first off, our patient is a 35-year-old male who presents with the chief complaint of quote unquote, my heart is beating out of my chest. He has no significant medical history. So what would you like to know about this patient? Anytime I got on scene, I always wanted to make sure I knew what their vitals were so I knew what I was working with. So blood pressure looks better than mine at 108/78. Heart rate rapid and thready, around 180 beats per minute. Oxygen saturation was 97% on room air, and his glucose was 112, which is completely normal. So what can I tell from this? This patient has an extremely high heart rate, so that's going to help me narrow down some of my differentials based off of that. So now we get a 12 lead of the patient. I want you to pause this video here and see what you can find. What's your interpretation and what's your treatment for this patient? So here's the first thing that I noticed. I noticed that it's a rapid rate, about 180 beats per minute, which is definitely tachycardic. But let's break it down a little further. So I want you to ask yourself, is this a regular rhythm or is it irregular? Is the QRS wide? Is it narrow? And are there P waves present? In this EKG, we can see a regular rhythm and a narrow QRS complexes, indicating supraventricular origin. Narrow complex tachycardias with irregular rhythm often point us towards supraventricular tachycardia or SVT. At this rate, it can be challenging to spot any kind of P waves, but as I mentioned in another video prior, that you could always do a Lewis lead if you're concerned about P waves and they're really hidden. In the cases of SVT, the P waves can be hidden within or right after the QRS complexes. So if you see in V1, which is one of the best leads to see atrial activity, I see a pseudo R wave in V1 and a pseudo S wave in lead 3. Based on the presentation and EKG findings, our primary suspect is a type of SVT known as AV nodal reentry tachycardia or AVNRT. The most common type of AVNRT is slow fast type, and that's what this is. Is that really important? No, not at all. But for those who want to know, there's your information. You can also see lead 1 and AVF are positive, so it's going to have a normal axis. So what is SVT or supraventricular tachycardia? So let's break it down. Supra means above, ventricular means ventricles, and tachycardia means over 100 beats per minute. So a rhythm originating above the ventricles at a rate of 100 beats per minute. Since it is above the ventricles, the QRS should be narrow or less than 120 milliseconds. The most common and the one that we think of when we hear SVT is AV nodal reentry tachycardia or AVNRT. In AVNRT, there is a reentrance circuit in our AV node. Usually this is kicked off by a premature beat such as the PAC. The next most common one is our atrial ventricular reentrant tachycardia or AVRT, which is most commonly seen in patients with WPW or Wolff-Parkinson-White syndrome, as the bundle Kent is an accessory pathway which connects our atria or top part of our heart to our ventricles or the bottom part of our heart and bypasses the AV node. Another SVT type is junctional tachycardia, but to be honest, there's a whole list of SVTs. Just remember SVT is an umbrella term which encompasses many types of rhythms, and for the most part, differentiating between AVNRT and AVRT and other types isn't super important and is a problem for the EP lab. So now that we suspect AVNRT, let's discuss treatment options. Since the patient is stable, our first approach is going to be vagal maneuvers. These maneuvers stimulate the vagus nerve, slowing down conduction through our AV node and potentially interrupting the reentry circuit, which is causing our tachycardia. I personally use the modified Valsalva maneuver a lot as a paramedic. To perform this, you place the patient in a semi-recumbent position and have them blow into a syringe for about 10-15 seconds. Then you lay the patient supine and raise the legs at about a 45-degree angle. And you can repeat this a couple times. A few other vagal maneuvers can be done as well. In pediatric patients, you can actually place their face in cold water, and that can help convert them. Another one to do is a carotid massage, but I would leave that to someone who's extremely comfortable doing them and has taken appropriate precautions, so I don't recommend people using this method. If vagal maneuvers don't work, the next step is going to be adenosine. Adenosine works on the adenosine 1, 2A, 2B, and 3 receptors, and it slows AV nodal conduction time and interrupts the AV reentry circuits using the A1 receptors. It has an extremely short half-life as it undergoes rapid metabolism, so placing the IV as close to the heart as possible is preferable, and I always slam a flush after it to give it that little extra kick and push. If the rhythm is really just atrial fibrillation or atrial flutter, You'll have flibbertory waves or visible flutter waves seen after the adenosine is administered, and then the rate will increase back to where it was before. But if the patient is unstable with a low blood pressure, altered mental status, or significant chest pain, in that case we move straight to synchronized cardioversion, Edison before medicine lab. So in summary, we're able to determine this patient had AVNRT, which is the most common type of supraventricular tachycardia. We know that he was stable, so we're able to do vagal maneuvers, and we could also push adenosine if that did not work. If he ever became unstable, we can go immediately to cardioversion. We also learned that SVT is an umbrella term that we commonly use to make it super simple to understand. There's tons of different types of SVT. Just make it simple and just put it underneath the umbrella term. If you're doing boards, the answer for the most common SVT is going to be your AV nodal reentry tachycardia. Thank you so much for watching. Like I said, my name is Matt. If you enjoyed this breakdown, don't forget to like, subscribe, and leave a comment below with your thoughts or questions. Stay tuned for more EKG cases and clinical tips, and I'll see you guys next time.